I'm going to do something a little differently this year than I've done in other years. What I'm going to do is pose 6 questions. If you know the answers to those questions, you can go and visit next door right away rather than waiting. If you're not quite sure about the answers, neither am I totally, but I want to discuss what we know to date on some of these issues. So one of the questions are, why are some patients able to cry and laugh but have abnormal voice control for speech? And I'm going to discuss what we know about the central nervous system that can address that and get to the other questions in a minute. So there are 2 systems for voice in humans. One system is the mammalian vocalization system. This is present at birth and also in other mammals. This is responsible for the cry at birth and responds to pain, hunger, sex, and isolation. So this is not a system that responds to auditory input, but rather responds to whatever is wrong with the person or other things in their environment. It also involves the cingulate gyrus and the periaqueductal gray, which I'm going to show you where those are. The pattern generators, that is the controllers for innate vocalization or mammalian vocalization, are thought to be in the pons, which is the upper part of the brainstem, and involves the brainstem motor nuclei. So this system is present at birth, responsible for the birth cry, and also is seen in other mammals. However, that differs from the vocalization system that we learn for voice and song. This is a cortically driven system. It is developed through auditory input usually. It's something that's learned, and it involves cortical mechanisms. And we think that some disorders such as spasmodic dysphonia, which affect the cortical learned system but do not affect the innate vocalization systems such as in laughter and cry. And those 2 systems can be disassociated in some disorders such as spasmodic dysphonia. Now, this is an image that was done by Jurgens, who spent many years studying vocalization in the squirrel monkey. And everything in this diagram that is hatched with gray, the monkey didn't need in order to produce vocalization. So almost the reverse to what we know is important for voice and song, which is learned in human beings. Only the periaqueductal gray and some of the pons and brainstem nuclei were essential for squirrel monkeys to be able to produce their vocalizations. Now, input to that system comes in the cingulate gyrus, which is beneath the cortex, and also in the amygdala and some of the other components of the emotional system. And this system has input to that innate vocalization system in humans. So if we take our diagram of what we've discussed for emotionally driven pain, sex, vocalization in humans, we're taking the mammalian vocalization system and putting this in the central nervous system with the cingulate gyrus and the amygdala having input to the periaqueductal gray, which then sends stimulus down to the pons and to the brainstem for elicitation of innate vocalization. Now I want to discuss the learned system of speech and song. Those depend on input from the auditory system. That's where the target comes, and the infant, through many approaches to model those targets that are in the environment, gradually learns speech and song, and this is a cortically driven system. This is an old diagram from Penfield and Roberts where they mapped out the cortex in patients who had temporal lobectomies, and they wanted to see which parts of the motor system controlled voice. And one thing I'd like to point out here are the throat muscles, which include the laryngeal muscles, are at the bottom end of the motor strip, while vocalization and voice control is higher up in the M1 strip. This is also the ability to elicit vocalization in this higher area was shown in some of their raw data on which parts they stimulated in order to produce vocalization in humans. But they could disrupt vocalization from many other areas. So this high mid-portion part of the lateral strip is where vocalization control seems to occur in humans. So this learned system seems to have the laryngeal muscles at the bottom end of the motor strip, but a vocalization system, which seems to be learned in humans from auditory input, is above that, and an integrative system in the cortex. Now, this system is complex. It involves many parts of the brain, and this is illustrated in an old fMRI study here showing which parts of the brain are active for somebody producing ee-hee, which is sort of what I call a laryngeal vocal gymnastics for speech. You have to be very accurate on your timing of this. The supplementary motor area, which is a planning motor area, was active. The M1 cortex, which we already discussed. The basal ganglia, which I'm going to discuss in a minute, and the periaqueductal gray down here, and the pons area, as well as the auditory area, which is the major input for feedback of whether you've met the target or not. Now, interestingly, it's mentioned that respiration is extremely important for speech control, and we see this in the brain as well. This was the same study by Tori Laux, and when they compared vocalization at rest with exhalation at rest, there was still seen a left hemisphere activation for an exhalation, controlled exhalation, much as what we use in speech, showing this learned activity in the respiratory system on the left hemisphere, similar to what happens for voice. So this respiratory control for speech is something that's very learned and active in the same region in the brain. Okay, so now we'll go back to our diagram where we showed the innate vocalization system coming from the cingulate down to the periaqueductal gray and the brainstem. For the human learned vocalization and speech system, you have the auditory input into the M1 area for both the laryngeal muscles and the vocalization. And that has a direct pathway, the cortical bulbar pathway, down to the brainstem, not going through some of these intermediate stages as occurs in the innate system. This direct pathway can be seen if you stimulate the brain in an awake person. You can produce a response in a laryngeal muscle within 12 milliseconds. This is a very short time and shows the direct communication from the cortex down to the laryngeal muscles in that very short, rapid time. That allows us to be able to control these laryngeal muscles very precisely in time. So to compare the innate and the learned system, one has input from the cingulate, the other has input from the supplementary motor area. One involves the periaqueductal gray and responds to anger, hunger, pain, sex, and isolation. The other has input from the thalamocortical pathways and responds often to self-initiated vocalization and speech for communication. One involves central patterning circuits in the pons, the other involves this premotor strip vocalization area. One involves the reticular activating system in the pons and the brainstem. The other involves the primary motor neurons in the M1 and sends axons directly down through the cortical bulbar pathway. Both have input to the laryngeal muscles through the final common pathway in the ventrolateral brainstem. So the answer is, why can some patients produce laughter and cry but are impaired in their speech and song is because we have two systems. One is learned and is the one that's most likely involved in some of our voice disorders, even though patients can laugh and cry normally. Okay, the second question is, what brain lesions can lead you to a vocal fold paralysis? We know that if I have a brain lesion in the motor cortex, on the right side of my brain, in the hand area, I'm going to have a paralyzed hand on the left side of my body. And that's because the right hemisphere controls the left side of the body and vice versa. What brain lesions will give us unilateral vocal fold paralysis in the larynx? Well, let's first of all look at the hand and the face representation, and the laryngeal muscles are down at the bottom of this motor strip. And all of these cross over in the midline in the brain stem, and so you do have a contralateral output from the ipsilateral stimulation. However, there is something different about the larynx and some of the facial muscles, in that both hemispheres have input to both sides of the larynx. That is, I have an ipsilateral downward control from the right hemisphere and a contralateral downward control. So if I'm looking at my left cricothyroid muscle on the left side of the larynx, that muscle can be activated by stimulation either on the right side, the contralateral side, but also on the left side, which is the ipsilateral side. So there is bilateral input to this left cricothyroid muscle, and I can produce a twitch in that muscle by stimulating on the right side of the brain, but I can also produce a twitch in that muscle stimulating on the left side of the brain. So this shows that there is bilateral input to each of the laryngeal muscles from the two hemispheres in the brain. This is illustrated here. However, we must remember decussation, that is the crossover point. The same as happens for the limbs, so the right cortex input will go down to the left nucleus ambiguus, and the left cortex input will go down to the right nucleus ambiguus. However, we also have ipsilateral pathways that go left to left and right to right. It's only if I have a lesion below that decussation point that I will get a unilateral vocal fold paralysis, and that's only in the medulla, in the brainstem. So that's the only place I can, in the central nervous system, produce a long-standing vocal fold paralysis, because I've affected the input from both sides of the brain to the nucleus ambiguus, where the motor neurons are for the laryngeal muscles. And this is illustrated here. Wallenbergs Syndrome, which is usually due to an infarct in the posterior inferior cerebellar artery, will impact the nucleus ambiguus on one side of the brainstem. And in this syndrome, you will see a unilateral vocal fold paralysis. You often will see a very severe swallowing problem as well. Okay, so the answer, the only unilateral damage is below the decussation, which affects both the ipsilateral and just one side of the nucleus ambiguus. All inputs above the decussation point have bilateral input to the larynx and do not produce a vocal fold paralysis. Okay, next question. We've asked a lot about sensory input to the larynx, and we know that the patient's coughing can interfere with talking, and we know that there are also protective reflexes in the larynx that are very important. Thank you for coughing on cue. Okay, so where are the sensory afferents for these kinds of reflexes? There are two types of sensory afferents. They're the supraglottal and glottal, and then there's the subglottal. The subglottal are the afferents in the trachea, which are innervated from the recurrent laryngeal nerve, whereas the supraglottal and glottal afferents are by the superior laryngeal nerve. And those have inputs that go through the superior laryngeal nerve and are separate from those in the trachea. You can study, and in fact people have studied, the effect of using an air puff, which is a mechanical stimulus, on the mucosa in the larynx, particularly in the posterior region where these mechanoreceptors are most dense. And you can see a bilateral thyroarytenoid muscle response to the stimulation at the level of the glottis or above the glottis that is called the laryngeal adductor reflex. And this occurs at around 80 milliseconds. And this can produce a bilateral response. Both vocal folds will be seen to close. If I stimulate the superior laryngeal nerve electrically, I will see an early response that's just ipsilateral, but I will see this late laryngeal adductor reflex that's bilateral and affects both sides of the larynx. This laryngeal adductor reflex is not a stretch response. We did some studies many years ago. We stretched the thyroarytenoid and the cricothyroid muscle and found no reflex in response to stretching those muscles. But they are dependent on mechanoreceptors in the laryngeal mucosa. In a cat study, if we excised the laryngeal mucosa, we were able to wipe out this reflex. So this reflex is very dependent on the mucosa in the larynx. Well, that raises a huge question. Why don't we have this reflex every time we go to talk? And that's one of the things that I'm going to address in a minute. Now, this reflex, the laryngeal adductor reflex, differs from the COFF reflex. The laryngeal adductor reflex depends on the internal branch of the superior laryngeal nerve, goes through the nodose ganglion, and is projected to the nucleus tractus solitarius in the brainstem. This is again also sent up towards the cortex, and you'll get cortical responses to this stimulation. The COFF reflex, on the other hand, depends on the recurrent laryngeal nerve, and those have their cell bodies in the nodose ganglion and then send inputs both to the nucleus tractus solitarius but also to the dorsal vagal nucleus in the medulla. So let's compare the laryngeal adductor response and the COFF response, because these are often confused. One, the laryngeal adductor response only produces a bilateral control closing the two vocal folds. The COFF reflex produces both respiratory changes as well as changes in the larynx, in that you produce a rapid inhalation, vocal fold closure, and then a rapid expiration to clear the trachea. The laryngeal adductor response, it occurs to unilateral stimulation. So again, it is a bilateral response affecting both sides of the larynx. The input to the laryngeal adductor response are mechanoreceptors in the mucosa over the arytenoids. These depend on pressure changes and chemical changes in the larynx. The input to the trachea includes both chemical receptors and mechanoreceptors in the trachea. So these have different sources. So the internal branch of the superior laryngeal nerve produces the laryngeal adductor response. The recurrent laryngeal nerve produces the COFF response. So how can laryngeal injury affect some of these reflexes and some of this control? Because we worry a lot in the clinic about things such as GERD, where there's acid pooling on the vocal folds, and whether that changes your response to talking and coughing. It has been shown in animal work if a low pH, that is an acidic substance, is put on the vocal fold mucosa, affecting those responses, the mechanoreceptors and chemical receptors in the recurrent laryngeal nerve, that you will get an immediate increase in the thyroarytenoid muscle. So this is a very acute effect. If I drop low pH on your vocal folds, similar to the dog, you will get an increased response in the thyroarytenoid muscle. This may be some of the tightening that we see in the larynx when somebody is being exposed to acid and other stimuli. Okay, but there are also brainstem changes that are chronic. Christine Simignon did a study in the rat where she produced, did lipopolysaccharide to produce an inflammation in one vocal fold, and then she allowed the rats to recover after 3 days, and this healed quite nicely. You could still see where the injection was, but it healed quite nicely. But then she put the rats down 3 to 5 days later and found that there were changes in the brainstem. These rats had increased firing in neurons in the brainstem 3 to 5 days after resolution of the peripheral injury. Although there was no peripheral injury, it resolved, there was increased firing in sensory neurons in the brainstem, as well as in some of the more motor reflex involved areas. So this suggests that when we do something to the larynx, either by increasing pH, we'll have acute effects, but if we have long-standing inflammation, we can have chronic effects, which will increase the brainstem neural response to stimuli. So this is not a benign instrument, our larynx. It responds to stimulation. The brainstem can become more active after there is repeated injury to the larynx. So acute injuries cause an increase in laryngeal muscle activity. Chronic injuries can cause central changes in the brainstem, making it hyper-responsive to sensory inputs. Okay, so then I asked earlier the question, why can we talk without producing these laryngeal reflexes? Well, our evidence there is a little bit more indirect. This, I showed you earlier that if you do an air pressure pulse on the mucosa, you will produce a laryngeal muscle response within 80 milliseconds after that pulse. Now, we know when we look at the larynx in stroboscopy, you can see this banging of the two vocal folds together. So there is stimulation going on when we're talking. So the question is, why do we do that when we talk but don't end up with a laryngeal adductor reflex? And so this was a study that Pam Kearney and I did some years ago where we did 2 air puffs. One puff and then waited a couple of seconds and did another puff. And we wanted to see if the response to the second puff was the same as the response to the first puff. And here you can see the first response and the second response. And the second response dissipates if you do this more and more frequently. That is, the brainstem has inhibitory mechanisms to say, okay, I'll respond to your first puff, lady, but don't keep doing this because I won't respond anymore. And so this shows exactly that. Here's the first response at different intervals, and as we shorten the interval and make the interval more quick, then these inhibitory mechanisms suppress the response. Now, we have found this in healthy controls, but we've also found this inhibitory mechanism is not there, is reduced in patients with spasmodic dysphonia, for instance, suggesting that some of these inhibitory mechanisms can be affected in some of our voice disorders. Okay. Now, the final question is, what about the basal ganglia? People don't talk about the basal ganglia much when they discuss central nervous system. And I just want to address what we know about that and the effects of that on the control for voice, because one of the basal ganglia disorders that speech pathologists treat regularly is using the Lee-Silverman voice therapy technique for patients with Parkinson's disease. And so how is this working and why does this work? Well, first of all, the basal ganglia is a modulation system. It modulates the cortex, and the way it does this is there is feedback from the thalamus to the cortical motor areas, and this is known as the thalamocortical pathway. And this can modulate the cortical programming that we talked about for voice. And there are many complex diagrams of the basal ganglia, but let me just use this one for a minute, which is old but still pertains to some degree. Here is our controlling in the cortex of the supplementary motor area, the primary motor area, and the motor cortex for producing voice. That sends inputs down to the putamen and the globus pallidus and the subthalamic nucleus. And these nuclei can be inhibitory, such as in red, or excitatory, such as in green. If the modulation of these nuclei become abnormal, then they have increased inhibitory input to the thalamus. Now remember, I talked about the thalamocortical pathway. This is an extremely important pathway that is excitatory. That is, if the thalamus has input and the usual input to the cortex, it helps with motor programming and helps excite the motor programs in the cortex. However, if there's too much inhibition, then the thalamus will be inhibited and there will be less input to the cortex. And that's exactly what happens in some of these disorders, such as Parkinson's disease. The thalamic input to the cortex is inhibited because of increased firing in the basal ganglia. That's a sort of an overview. Now, how does this affect voice control? Here are laryngeal EMG recordings in a normal person saying CE, 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 and in a patient saying CE. And you may not be able to see that from where you are, but this is the thyroarytenoid muscle, and that has a level of 2,000, whereas in the normal control, it has a level of 400. What has happened is that this hypertonicity has overridden and blocked the patterning that's normal for being able to do this rapid control in the laryngeal muscles. So what's happened is that there is a hypertonicity that overrides the ability to do volitional programming of the laryngeal musculature. Now, Lushai, many years ago, studied the effects of levodopa, which is used to treat Parkinson's disease, where you increase the dopaminergic levels in the basal ganglia. And he found that the rate of motor neuron firing was reduced with levodopa, and the amplitude of muscle recruitment was reduced with levodopa, which is a good thing. That is that hypertonicity is reduced. But he found it didn't increase volitional activation. And that's probably why LSVT is helpful in Parkinson's disease, even though levodopa doesn't have as much effect. Because the LSVT addresses the ability of the patient to behaviorally control the laryngeal muscles by upregulating and using loud speech, even though the levodopa reduces some of that basal ganglia hypertonicity, it doesn't help the cortical activation. So these two parts of some of these disorders are important. So the answer is basal ganglia disorders can increase the firing from the basal ganglia that will suppress the thalamic input to the cortex, thus reducing cortical excitation for volitional control for the laryngeal muscles for speech. And that's why addressing the patient's cortical functioning and increasing that will help these patients. So, answers to the 6 questions. I hope I've addressed those, and I think I'm now close to the end of my time, so I'll leave you with those answers. Those are the answers this week. They may change next week, so stay tuned, and hopefully we will learn more and more about the central control of the larynx in the future. Thank you for listening.